and then introduce two more trocars on the side of the first one.
Okay. Do you need to create a subcutaneous space or just put a trocar on both sides?
If the tissue is not pliable, it won't stretch. Yes, I would undermine the skin a little bit
Okay.
to create space, because you need to. It's a vertical incision
Okay.
which is being used for trocars going in the axis or in the center of it.
Okay.
So it turns into like a diamond.
Okay.
If it was a transverse incision, there'd be no problem. But since a vertical incision, you have to undermine a wee bit if required.
When you're closing the wound now, are you trying to take the two 5 holes within your sutures?
No, the 5 millimeter in the rectus
Don't need to be closed.
sheet, you don't need to. I mean, normally you don't close a 5 millimeter, and here they are. This incision is in the linea alba. Those 5 millimeter go through the anterior rectus sheath, the muscle, and the posterior rectus sheath.
Yeah.
Once you withdraw the 5 millimeter, I don't think anything stays there to close it.
Okay.
And since this is a midline incision, those are too lateral to incorporate them in any way.
What should be side of entry for 5 up just above and below?
The site of entry for 2 ports are just at the same level of the 10 port. They are not just above or below.
If you put them above or below, then they start clashing.
Okay.
Because imagine 3 instruments traveling together. If they were above and below, then you would have them clashing inside.
So
That can be overcome, which means the person holding the camera and the person using the instrument have to kind of give each other space. And that's the wound. And I close the dead space so that we don't have any seroma and hematoma collecting, and then use the same suture for a subcuticular closure of the skin, which leaves a nice scar. ये needle hold दूसरा है. Needle holders that don't work. I spent 25 years working for the government and got used to them. It's like good memories. ठीक है हाथ में. Now when you look at the final wound, the bit in the umbilicus is not going to show. The bit above is all that there will be left to form a scar. That's it. If there are any questions, I'll be only too happy to answer them.
Thank you very much.
Pleasure.
Sir, if there is no state for gallbladder, can you go for the same cells, or if there is a technically difficulty we can come across?
My answer is you are here to do a cholecystectomy. Cells is only one way of doing it, which tends to turn out to be cosmetically a little better. I don't think you should compromise on the procedure by making your life difficult or making the procedure difficult and subjecting the patient to some risk. So if it doesn't work, introduce more ports and complete the procedure. That is what I would advise.
In this procedure, sir, we have not seen properly the cystic artery, but it might be burned or it may be into the clips.
Yeah.
So say for the we come across, it should be scatolized first or the cystic duct first?
I think the principles apply that you have to have 2 windows, one window between the cystic duct and the artery and the other between the artery and the liver or the gallbladder. Once you achieve that, you are safe. The principles do not change. In this case, either I burnt it or it was not big enough to separate it individually. I had a big window behind between the cystic duct and the liver, so I clipped. And if the artery was in it, it's safe. It wasn't. Still, it's like it's been taken care of.
Okay, sir. Thank you.
Mastectomy, 25-year-old married female with a upper abdominal pain for 1.5 years. The examination was normal and she had multiple gallstones and also one stuck at the neck of the gallbladder. Dr. Mumtaz Meher is going to perform the laparoscopic cholecystectomy.
Do you get a view now?
Yes, we can see the umbilicus right now.
Good. Yes. Yes, on. Yeah. Okay. नहीं ज़्यादा है. Okay. Right. Okay. Forceps then? Hold it. Okay, take it out.
Can you listen to us, sir?
Yeah, I can hear you.
Are you using the umbilical cord right through the umbilical cicatrix?
You can. I think as long as you close what you open, there's nothing wrong, and if the umbilicus is clean, there's nothing wrong with it. There's nothing kind of holy about the umbilicus. You can use the umbilicus, don't use the umbilicus, doesn't really matter. The umbilicus just offers a central point as well as it becomes cosmetic to hide it there. But there's no point in using the umbilicus and leaving it distorted or leaving it as a source of infection.
The second question is that are you putting all three ports in midline or
No,
off
no.
midline?
No.
The 2 5 mm?
You know the principle of triangulation stays, it's only that the triangle here becomes narrow. Because you can't be putting three instruments together in one line. You still have to have triangulation. Thin, very thin patients. We need a little give for the instruments to go in. Because pull. 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 Yeah. Point them towards the gallbladder. Have them all pointing in one direction. That way they don't clash.
Please, will you show laparoscopic view?
ऐसा दो ना.
There is a question from the floor. Please show us the exact site of the port.
Yeah, okay. You know, imagine 3 instruments. Can you see me?
Yes.
Imagine 3 instruments traveling together, right? Now, with the telescope going in and 2 instruments coming from the side, you have to have them placed so that they don't override each other. That's the basic principle, which means if you have them up like this, they will maybe be all right, but I have them almost in the same line so that they don't clash.
Same transverse line.
Yeah.
And you place the left instrument for using the right side. Do you cross them?
No, I don't cross them. You see, that's the whole idea. I have 2 instruments coming in. This is my right hand.
Right.
And this is my left hand. Now you see the left hand is coming from a little higher. Okay? From a little higher, not an advantageous position. It will cause a lot of clash. Best not to cause them to clash. This rotation. This is my right, this is my left. See how they come in? The triangle is narrow, but you have to have them to triangulate. You lift it up, and then you assess as to where you want to hitch it, because this is the area you want to work in.
Right.
And if I hitch it here, if I hitch it here, I'll have the stretch on this.
Right.
If I hitch it here, like over here, then this thing goes up, it's still sagging here. So it'd be better to hitch it a little lower down depending on the length of the gallbladder. If I hitch it here and it goes up, it'll be kind of serving a purpose. You look at the rib margin, over dekha, 6, rib margin and niche gallbladder dekha, and decide the shortest distance to the gallbladder.
Right.
And we use a straight needle. Come in. Yeah. Pull the needle in and give it a little bit more length so that on the way out you're not cutting the gallbladder. मुझे एक गॉज देना, ये निकालो. Because there's going to be a little spillage of bile, I'll put a little piece of gauze so it keeps the bile from flowing out of control all over the place. Okay. Fighting. Flash button. The needle is long, so I need to hold it a little further up so it doesn't go through the liver, and always come from up down, right?
Right.
If I hitch it here, the point is if I hitch it anywhere, I can have a little slack on it to loosen it, but if I have it too loose, I can't make it tight.
Right.
Because There it is. Okay, साफ करो. Let's have it staggered. So now, as compared to the last case, I have one instrument in my hand that I can use like in a conventional cholecystectomy to work for me. Previously, I was using the left one to hold the gallbladder. Now I have it relatively free. I can use a hook or use a grasper, whatever suits you. I can see this as the common hepatic duct. This is the cystic artery. Don't see the cystic duct yet. But if you breach the peritoneum, stay close to the gallbladder, you won't go wrong. And let the gallbladder guide you to the cystic duct. The advantage of having Kelly's in your hand is that you can kind of have two graspers working for you. Go further up or down. Release the gallbladder a little bit down here. The advantage is that you let this procedure slow you down. When you slow down, you are looking after hemostasis and doing these maneuvers without any haste. The restriction actually works to your advantage in slowing you down. That seems to be the artery and that the duct. दिखाओ. There's no hurry. A cholecystectomy basically involves ligating or clipping these two structures and then separating the gallbladder. This is of paramount importance that you don't rush through here. Only proceed when you are certain that you've got these two structures under control, and what you are clipping is actually the cystic duct and not anything else. So there shouldn't be any rush. पीछे देखो टच तो नहीं कर रहा है ठीक है The artery you can clip anywhere. The duct you need to at least not leave a long stump behind because it may be a source of some symptoms later on. And sometimes we leave a long stump and there's a stone in it, it will grow into what will look like a new gallbladder. The patients are usually very upset to think that the gallbladder was never taken out. Now, here we have a window, and if you want more clarification, anything that you do now is something that you'll be doing later, so you can do it now and have everything clarified before you clip and cut. We know the common hepatic duct is here, so we are far away from anything important there unless there is a cholecystohepatic duct here. So I'd be quite happy clipping these. Okay? There's something there, you know? Structure there. You clip it anyway. चलो नहीं हाँ चलो वो करना है This time I'll not use the Ligamex, I'll use the conventional green medium large sized Liga clips, for which you need to swap the telescope from 10 to 5 mm and go through a 5 millimeter port. Right? The view has slightly changed and it's coming from the right hand trocar and the clip applicator coming through where the 10 millimeter telescope was. We know that common hepatic is far away. If anything, I'm clipping it close to the gallbladder. एक और देगा ना मुझे There's a tubular structure here. I don't want to take any chances. Now one can use the 5 millimeter, which is a good quality telescope, to use it through an introducer. Saves you swapping things, but that doesn't take much really, only a few seconds. Scissors. A little patience and a set of maneuvers is all it takes. नीचे नीचे टच करो